Thank you, Dr. Hughes. It was really fantastic, wasn't that? I love the pictures, too. It really lets you see what's happening. We now have a panel session from Research to Reality, Transforming Transplantation and Liver Cancer Care. Our moderator is Dr. Scott Biggins, and we have panelists Nancy Jasso, Dr. Monga, Laura Sinwar from CORE. Dr. Scott Biggins is a distinguished hepatologist recognized for his leadership in liver transplantation and liver cancer care. His research and clinical expertise emphasize bridging the gap between discovery and clinical application. As a moderator, Dr. Biggins will guide the discussion and bring together diverse perspectives to eliminate the opportunities and challenges in transforming transplantation and oncology care. Please join me in welcoming Dr. Biggins and our panelists.
Thank you, everybody, for joining. We may need an extra chair up here. I don't know if we're going to do that, but I really have the true pleasure to work alongside Dr. Chris Hughes, who you just heard from quite a bit, and you see a lot of those drawings. Those are your drawings, aren't you?
Don't admit it. I don't admit it.
Yeah. So he's not only just an accomplished clinician and surgeon, a pretty impressive artist too. So the next part of this, we're going to be going from research to reality, and we have a series of speakers that will be here. We'll go from the lab with Dr. Paul Monga, who's getting his slides set up here in just a bit, to how the organs are procured from the OPO and this pumping technology that you heard a bit about, and then a real special treat from a patient, a liver transplant recipient. So this is going to be quite a treat for you. So first we'll start with Dr. Paul Monga. Dr. Paul Monga is an endowed chair of experimental pathology. Just so you realize, this is like the people that, change academics and change science. He is a pathology professor. He's an associate dean for research at UPMC. He's an executive vice chair of pathology and the chief for experimental translational pathology. He has not one, not 12, but 17 NIDDK awards. This is the NIH funding that's so hard to get nowadays. And his lab is doing really cool stuff. He's going to talk about quite a bit of cancer here, but there are other things where he can put, it's called biometabolic twins, is that right? So to put liver cells on a plate, to put intestine cells on a different plate, to have feed those cells just like they're connected in a human body, to see if medicines would work in that environment, and then you can translate that to others. So just some stuff that he may not have time to talk about, really impressive stuff that he's doing in his lab. So my friend, Dr. Paul Monga, thank you for joining us.
Thank you, Scott. Appreciate it. All right, that was great. This works. Well, thank you so much, Scott, for that very kind introduction, and thank you, Susanna, for an opportunity for me to be able to discuss some of the things. So I was again given a title by Susanna to talk on research in HCC, some of the unmet needs in the clinic. So that's what I'm going to talk about. So we all heard from Chris, liver cancer remains a big unmet clinical need in the clinic. Actually, this problem is worldwide. It's the 6th most common cancer in the world and the 3rd most fatal cancer. And if you look at the age-based incidence, again, as Chris had mentioned, this is not a disease that occurs in young individuals. The peak incidence of HCC is anywhere between 55 to 74 years of age. Median age of diagnosis is 67. And this is because most of these cancers happen in the backdrop of chronic liver injury and disease. So you will have a healthy liver, you transition to a fatty liver or some other form of chronic injury, which then results in fibrosis, eventually cirrhosis, and then cirrhosis becomes a big risk factor for development of liver cancer. So it takes years and years of insult. So I thought I'll give you an overview of what happens at a microscopic level of how cancer first starts. So this is
Your slides are not showing up.
Oh.
So I'm not sure.
Oh, I'm so sorry. Are you sure that will work? Oh, so sorry, guys. Maybe I don't even need my laptop then, right? Okay, all right. All right. Okay, so I think not important. Here we go. So this is the important part. So because of any of those diseases that I'm mentioning up, oops, so the pointer here is right here. So any of these chronic diseases, alcoholic liver disease, metabolic dysfunction associated steatohepatitis, hepatitis C, hemochromatosis, any of these, the cell that is injured, and again, Chris alluded to that, for most of these, the cell that is injured or hurt is hepatocyte, which is the workhorse of your liver. When this cell is injured, it dies. And as it dies, it releases some factors called DAMPs, or damage-associated molecular patterns. Once this happens, these DAMPs invite inflammatory cells into the milieu. With inflammatory cells come free oxygen radicals, which cause DNA damage and injury. Now, as hepatocytes are dying, remember that there are other hepatocytes in the area which have escaped this, and they will start to proliferate because liver has the capacity to regenerate. It has to maintain its size. So one cell dies, another cell divides to take its place. But as this is happening, there is also a lot of wound healing that is happening. And that's what the liver looks like. There is inflammatory cells here. They are fibrotic scars that are beginning to form. And you saw how that liver looks at a gross scale when surgeons take it out. But what all of this results is years and years of insult and injury. But what is going on at the time is the hepatocytes that are dividing, their DNA is more prone to injury and damage. And if any of that injury causes a mutation that allows for cells to survive, you will get a clone of cells that arise from these mutated cells, and then that one clone of cell is going to take a form of a cancer, and that's how this cancer is going to eventually look like. One cell that becomes malignant and then takes over the liver and becomes cancerous. And then over a period of time, additional mutations will develop and will also lead to cancer. But this can lead to tumor progression, and the tumor can also metastasize outside. I should also mention that there are certain different types of etiologies which bypass this years of insult and can directly lead to mutations, and that happens in some cases of hepatitis B virus, aflatoxin, which is common in Asia, but also in a subset of fatty liver disease patients. And those remain an unmet clinical need, and there's a lot of research that is ongoing in that area as well. But once these cancers form, they really start to make their own microenvironment. They will make their fibroblasts, they will make their tumor-associated lymphocytes, neutrophils, and all of that coexist within the tumor environment that allows the tumor to continue to grow. So one of the earliest events that happens are mutations in certain genes, including TERT promoter. And then right after this, there are a couple of other mutations like beta-catenin, P53, ARID, and NERF2, et cetera. So one of the ongoing research is there is really no precision medicine-based treatment in liver cancer. The best way is to diagnose it early. So there's a lot of importance of surveillance where patients, hepatologists need to follow these patients at the earliest signs of transformation. You are able to bring them because liver transplant eventually is the only curable treatment, or resection is the only treatment. So there's a lot of research to try to identify what these early lesions are able to secrete that can be caught in the blood. So there's cell-free DNA, that liquid biopsy. So there's a lot of work that is ongoing in that area to identify these cancers very early. There are also artificial intelligence-based techniques like radiomics. Because most of these patients can get CT scans and MRI scans, you can actually look at those CT scans and try to learn from them if there's a very early lesion that is not detectable by naked eye, but can be through a computer programming. So there's a lot of work going on in radiomics to also identify those very early lesions. Furthermore, deep sequencing has now revealed many, many molecular abnormalities in these cancers at very early stages. And this is a hallmark study from TCGA, the Cancer Genome Atlas, which has really, really identified many different mechanisms that drive this cancer. And a lot of these pathways that are activated in cancer are now targetable. So there have been drugs that I mentioned over here that specifically affect this part of the pathway, which is the growth factor pathway. So there are 6 or 7 options for patients to take that. But more importantly, the unmet need is that there are other very, very important drivers of this liver cancer, including P53, telomerase, and the Wnt pathway components. And these have been untargetable. So a lot of work is going on in the field to try to target these traditionally undruggable targets. So there's a lot of pharmaceutical biopharma that's involved in identifying ways to target this. And the last part is that because most of the cancers that happen in the liver are because of chronic insult to the liver. And again, I think Chris alluded to this, there are immune cells that exist that are always surveying for these cancers. So why then, if in liver cancer, when you have so many immune cells, why do these immune cells not catch the cancer and kill that cancer? And the reason for that is because the cancer cells and immune cells, they can coexist because there are certain factors called immune checkpoints that are upregulated by either a cancer cell itself or by immune cells. And these are called PD-1s, PD-L1s, CTLA-4, and they make the immune cells not recognize the cancer cells. So you will have immune cells and you'll have cancer cells, but the immune cells cannot identify these cancer cells and kill them. And that's where revolution in oncology happened when immune checkpoint inhibitors were identified to be those drugs that could start to downregulate those immune checkpoints. And now these immune cells can start recognizing cancer cells and killing them. And that has really changed the spectrum of for medical oncologists who treat liver cancer. And there are now in first-line setting, many different combinations that are available, including atezo-bev, durva-tremi, and ipi-nivo. And these patients can now show objective response rates of close to 30-35%. So almost 35 out of 100 people will be benefited from this. But still, only 35% patients are responding. So why are the remaining 65% not responding? So there's a lot of research that is going on in that area as well. So we need better biomarkers for patient selection. We need biomarkers of response. And most importantly, we need to identify why those 65% of patients are not responding to these very important drugs. So there's a lot of research going on in that area as well. So I'll stop here, and if there are any questions, I'll be happy to take them.
Thank you, Dr. Manga. It's really impressive to see the biology here, and it goes over my head. But his ability to really take these advances and then get them to the clinicians and is just amazing. I also say I had the opportunity to teach in the clinic one of his PhD students recently, and so another thing that Dr. Manga does is really train the next generation of clinician scientists, and now that same individual is working on his MD and is going to replace all of us in probably about 10 years because is just a wonderful rising clinician scientist. So next we have move on to kind of how we get the organs from the deceased donor organ donor to Dr. Hughes for a liver transplant. So we have Laura Sinar, who will be up here in just a bit. She graduated from the University of Toledo with a Master's of Science in Biomedical Sciences and Transplantation and Donation Science. So you can see she was really laser focused on getting to her job at CORE. CORE is the organ procurement organization that really works on all the logistics of getting someone from having that desire to be a life-saving organ donor and getting those organs to the hospital to help life-saving transplant surgeries like Dr. Hughes is having. So Laura, welcome.
Okay, let me figure out, how do I advance? Sorry about that. The green one. Okay, perfect, thank you. Good morning, everyone. Thank you for having me. I'm Laura Swiner. I'm the Organ Recovery Manager at the Center for Organ Recovery and Education. And at CORE, our mission is to save and heal lives through donation. Our vision is that every potential donor will make a pledge for life. And our values, we keep these at the forefront of every decision we make every day, are compassion, education, innovation, integrity, life, quality, respect, and responsiveness. So CORE is an organ procurement organization. We are federally regulated. We are a non-for-profit, and we were founded in 1977. Actually, right here, our headquarters are in Pittsburgh, Pennsylvania. We're one of 55 national OPOs, and our team consists of over 250 members to help us fulfill our life-saving mission. Our service area consists of Western Pennsylvania and West Virginia. We also have offices in Erie, Pennsylvania, Morgantown, and Charleston, West Virginia. We help partner with 7 transplant centers locally. That's Allegheny General, Charleston Area Medical Center, UPMC Children's, UPMC Hammett, UPMC Presbyterian, the Veterans Hospital of Pittsburgh, and WVU Medicine. We also partner with over 150 hospitals in our service area to help start that donation process. They are really key in making that potential referral to CORE on a patient that might be ventilated and there's going to be end-of-life conversations in the near future, or when there's an actual death at their hospital. Our team will evaluate for organ, tissue, and cornea donation. If there's a potential on a ventilated patient that they could help through organ donation, we do send a coordinator on site to work alongside the critical care doctors to complete a thorough evaluation and obtain a significant past medical history, along with any diagnostics that patient has had on that admit to evaluate them to be an organ donor. If there's even one organ that could potentially save a life, we will continue to follow that patient until that end-of-life conversation is held by the care team with the family. After that conversation is held, we will send a designated requester to go offer the opportunity of donation to that family. If they authorize, we will send a clinical on-site coordinator to manage that donor throughout the donation process, optimizing organ function, and they're also responsible for starting that match run with our donor to find the right recipient for those gifts. Once our allocation process is complete, we set up a recovery with the hospital operating room. And then we have coordinators in the OR that assist the transplant surgeons in perfusing the organs and flushing them, packaging them, and making sure they get transported to the correct transplant center for the recipient. Through this entire process, we are supporting the donor family, and we do have a donor family service department that will continue the weeks and months after the donation occurs to support that donor family. This is where we really find the duality of our mission, that we save and heal lives every day. So this photo is of Dr. Thomas Starzl. He holds a special place in our hearts here at Pittsburgh. He did the first transplant in 1963 in Denver, Colorado, and a few short years later, he came here to Pittsburgh to continue to grow transplant in our area. As you can see, he just finished his recovery with his sterile liver in his cooler with ice. I like that he's kind of holding on to the handle and someone else is really doing the carrying. Well, he had to do the recovery and the transplant. So that's called static cold storage. That is what we've done for the past 60 years since Starzl was able to do transplants in transporting all organs. They're recovered in the operating room, flushed with a perfusion fluid that's filled with electrolytes, replacing the blood supply of the organ. That gives us time from the donor recovery to the transplant into the recipient. And it also helps reduce the metabolic process on a cellular level, preserving that organ. Once that organ is packaged with all of that loose ice in the cooler, that preservation time can start. However, it doesn't stop ischemic injury to the organ. It also doesn't offer additional evaluation once that organ is recovered to the transplant team if there were questions after the recovery. What we've seen in the past 5 years is growth in machine perfusion, specifically to liver, heart, and lungs, that it can be an advanced method to address all of those limitations and also restore energy deficits on a cellular level, minimize ischemic reperfusion, and essentially keep the organs functioning in a physiological state like they would be in the body. So this is our traditional packaging. Like I said, over the last 60 years, I really think the major advancement was the tailgate cooler with the handle and the wheels. So we did not have to have surgeons carrying the organs after they were recovered. We also would transport organs in styrofoam boxes, and with this type of transport of livers particular, we had a maximum of 8 hours from donor to recipient to transplant. And in our area, we're also dealing with logistics, I think nationally, as far as weather. If we have a snowstorm or fog and a plane can't land, every minute counts when we're trying to figure out that timeline from donor to recipient. So the first thing I'm gonna talk to you about is Paragonix is an organization that started doing some research back in 2019 and had their first device approved in 2021. More specifically, their liver guard was approved roughly 1 year ago to transport livers. And this is a way, when we had that wheelie cooler and we would leave the hospital, when we tilt the cooler or we get in the plane and it ascends to fly, it shifts the loose ice around the packaged organ. And what this company found is that it was causing uneven cooling of the organ, sometimes freezing edges of the organ, causing delayed graft dysfunction. So with this type of cooler, we precondition some ice slats for 48 hours at -20 degrees. And in the bottom of the cooler is a tray. We put some of the ice slots in there and then put the tray lid down. We have the packaged organ, and then we have a tray on top with more ice slots. That way we keep the internal temperature of the organ at exactly 4 to 8 degrees Celsius, and the ice is never shifting around the packaged organ. It stays in one place. The FDA has approved this cooler for livers to be sustained up to 15 hours internally, and this has actually helped transplant centers go out farther to do recoveries for their recipients and accept more organs. This provides device monitoring. There's a GPS system in the cooler, and it also tracks the temperature monitoring the entire time the organ is in it. This has also reduced recipient complications. They have seen that when this type of device is used, that it reduces 2 ICU stays on the recipient end. There was a study done over the course of 4 years with a few select transplant centers. They studied 205 livers that were packaged in regular cold static coolers, and then 205 that the liver guard was used. They saw that there was a 51% reduction in early graft dysfunction. There was a 15% reduction in acute kidney injury in the recipients. And when they used this in combination with some of the machine perfusions I'm going to go over, they saw an additional 30% reduction in early graft dysfunction. So we're seeing devices used in combination, not just one thing or the other, which is great. So CORE is a Paragonics hub. We have partnered with Paragonics. Our organ recovery team went through training for their liver, heart, and lung devices, and we have those on hand at our facility. Anytime a transplant center is coming in for a recovery, we do let them know that these devices are available, and that's one less thing they have to bring to the recovery. These have also come in handy where we've had late intra-op declines on a liver 3 times, and there could be different reasons. It could be that the biopsy wasn't right for that recipient and the center might decline in the OR. It could be that something happened on the recipient end and they aren't ready for their surgery, where we've been able to reallocate the liver 3 times by having the liver guard on hand and sending the liver to the requesting transplant center. The other thing is they have broken records. The farthest liver has been flown from Puerto Rico to Tampa, Florida in one of these devices traveling 1,200 miles. So machine perfusion, this is the really hip thing right now we're seeing in the ORs. Over the last, I'd say, year, we have really seen increases, and I have a slide at the end. This is normothermic machine perfusion. I know Dr. Hughes got to touch on Transmedics a little bit. OrganOx is the other FDA-approved machine. These are the only 2 in the United States right now that are FDA-approved. They function in similar that they will take blood products to reperfuse the liver after it's recovered, and it gives real-time evaluations. We can look at lab work, such as lactate. We can also look at the glucose to see that bile is being produced and the liver is metabolizing. If needed, we will give Clinomix to help feed the liver and keep it functioning while it's on the pump, and this can prolong preservation times up to 12 hours. This is also additional ways that the transplant surgeons can assess the liver once it's recovered. This has allowed us to, on the organ procurement side, we continue to pursue older age donors or sometimes donors that have longer warm ischemic time. This will help revitalize the organ. So at CORE, we actually became, we offer OrganOx perfusion services. This is new at the end of June. We had a huge training with all of our local transplant surgeons. We're invited to learn how to cannulate the livers. All of our organ recovery coordinators were trained to be technicians. So that 12-hour waiting time that the liver's on the pump, somebody has to be with it. Somebody is drawing the labs and somebody is reporting that out. That is our team at CORE. So those are a few photos with our local surgeons, and that is an actual video from the training. You can see there's blood going through the cannulas, and we initially had albumin to prime the cannulas, but that's going to be pushed through, and you can see the liver start to pink up as the blood reaches a cellular level. Okay. So the other type of perfusion we're seeing, these are not FDA approved. They should be approved by the end of the year. There's 2 types of hypothermic oxygenated perfusion, also known as HOPE. One is Bridge to Life VitaSmart, where it's an open system. We just cannulate the liver on a back table and the pump sits on an IV pole. There is cold perfusion fluid that goes through and gets oxygenated. And with this type of pump, they're able to monitor, their primary focus is biomarkers to see if there's any type of inflammation going on a cellular level. The other type of pump is Organ Recovery Systems Liver Transporter. They've actually been around for about 40 years pumping kidneys, so this is a new device for them, but it functions on a similar way that it's really monitoring the flows going through the portal vein and the hepatic artery to see how that liver is intaking the fluid and flushing. Both of these can increase the preservation time up to 12 hours. This also expands the donor pool in a similar way of the other pumps, and it's user-friendly compared to the last pumps that use normothermic blood. There's a risk with those that there could be a clot. That's why there has to be a technician with it all of the time. With these pumps, since it's cold perfusion, the liver will always remain cold and be preserved. If something would happen, that a cannula would dislodge or there would be something that would go awry on the perfusion. So the last thing I'm going to talk to you about, CORE does a lot of partnerships with researchers. This is through Miro Matrix, and it's called the External Liver Assist Device. This treats acute liver failure, and essentially what we do when there's a liver that is not deemed suitable for transplant and the family has authorized for research, this researcher will take the liver and they will decellularize the hepatocytes off of it and keep the scaffolding of the liver. They are then regenerating hepatocytes and keeping it for when they're going through clinical trials right now with the FDA with certain transplant centers that are partnering with them. If a patient comes into the emergency room and is in acute liver failure, they can take one of these engineered livers, send it to the transplant center for treatment. And that's just a diagram of, they essentially describe it like dialysis, that there would be a port to the patient, to the pump, to the bioengineered liver, and those hepatocytes would function as that sick patient's hepatocytes, clearing out any of the toxins. And this is a short term, almost a bridge to transplant, like Dr. Hughes mentioned earlier, that it can either treat the patient and they can go home, or it can give them that bridge to transplant. So this is just through FDA trials. They did their first study with this with a patient back in June in Utah, and I believe they have to do about 12 of these cases before they can move on to the next phase. There's going to be 2 phases for the FDA trial, so I think this is something we're going to see in the future. They said that this is easier for them to push through regulations because it's not involving any xenotransplant. It's a human liver that they're using to regenerate the hepatocytes on. And this is just a takeaway from the innovations we've really seen increase over the last 12 months. So in 2023 is when we started to see transmedics in our local recoveries, and you can see that increase in 2024, and we started to see the liver guard. And then in the past year, you can see that we've introduced our OrganOx machine as well. And just looking at CORE's total livers that we've transplanted, you can see before that innovation mark between 2021 and 2022 that we've had a steady increase every year. And our numbers for 2025 were till the end of August. So I think we're going to surpass our 254 mark from last year. So these are just some of our statistics. We've had a 6th straight record-breaking year, and a lot of that goes to more people saying yes and offering the option for their loved ones to be donor heroes, and also these innovations that are making it remarkable and able for us to transplant more organs that, 2 years ago, we might not have been able to transplant without. So what we ask is for you to take action, to sign up and save lives, because everybody can be a donor. And I want to thank you for this opportunity. If you have any questions, we'll be here for the next few sessions.
Thank you, Laura. That is wonderful to see all this technology, and you can see just in the last, since 2021, if you look at that bar graph, there are almost 1,000 or maybe over 1,000 patients with liver disease that underwent transplant, and really a life-saving intervention and evolution of technology. I think what's really special about this program that the Community Liver Alliance put on is having so many patients here, both in the audience, to be able to engage with the clinicians and the scientists, and this is where I'm very excited to introduce Nancy Jasso, who first is a mother and a wife and a liver recipient. But I had a chance to just talk with her a little bit this morning, and if you don't mind me sharing, she goes by Nana to many of her family, as she is the mother of 4, the grandmother of 7, and the great-grandmother of 2. So this is, what it really just fills my cup when I hear things like that. And she loves gardening and adopts dogs. I think she said she had 4 dogs and 2 cats. So this is what we really see. This is, you know, all the science about all this has really led to Nana standing on this stage 10 years into her journey that she will share with you now. So, Nana, welcome.
Morning, everybody. All my people do call me Nana because they hear it a lot. I would like to start by saying my journey started, my whole journey got me here today, started when I began drinking at 12 years old. That was in 1980. It helped me to fit in with some older kids at school because I had a hard time with that before that. And I liked the alcohol. I liked the way it made me feel. It was courage in a bottle. And I continued that for 34 years. And at first it was just weekend drinking, and by the time I was maybe 15, I was drinking regularly, and I got pregnant and got married at 15. And my husband and I drank throughout our marriage. We were only together 7 years. The alcohol just ruined things. The alcohol's terrible in a relationship, especially when both people are drinking. And I left him. I was living in Louisiana. I left him and went to Georgia and lived with family there. And I was doing great. I remarried, and then I had 2 kids already at the time. But in 2005, I went through some difficult times and really started binge drinking a lot. I was drinking probably 4 or 5 fifths of alcohol a week, a lot of alcohol. And then in 2008, I started realizing I was having symptoms of liver disease. I didn't know I had liver disease exactly, but I was having things going on with my body, and I knew my body, and it wasn't normal. And then I started wanting to quit drinking, but I could not quit. I tried several times to quit unsuccessfully. I did not seek help. I didn't want to tell anyone. The stigma's terrible, and you don't want to go to someone and say, I have a drinking problem. But I finally did go to my doctor, and I had been seeing my doctor for other things. She was treating me for neuropathy, but she was not doing any liver function tests. And then my eyes started to turn yellow, and I started having aches and pains in my upper right quarter and vomiting a lot. So I went to my doctor and said, I think something's wrong with my liver. And when I did that, she did an examination. She felt me and said, your liver is huge. And then she ordered an ultrasound, and then she referred me to a GI doctor, and they both said, you cannot drink another drop. And they were doing labs on me regularly, but I was not given a diagnosis, and I did not seek treatment. I continued to drink. And almost a year later, I had the big GI bleed. I vomited most of my blood. I spent the weekend doing that, hoping it would just stop and go away, and I got weaker and weaker. And then on January 4th of 2015, my husband carried me into the hospital. And I had been drinking vodka still and left that bottle sitting next to the bathroom toilet where I had been vomiting. And I went to the hospital and had blood transfusions. I spent a week in there detoxing. I had wanted to quit drinking so bad, and after getting to the other side of that, I wasn't going back. I had too much to live for. I had people at home depending on me. I had people in my hospital room hoping I would come home. They were scared. They'd never seen liver disease. I had never seen liver disease. I didn't know anyone who had it. But that was it for me. It scared the living daylights out of me. And once I had gotten to the other side of the withdrawals, there was no way I was going back. And I went home sober, and I stayed sober. And When I went home, I saw that bottle of vodka next to my toilet. I was not happy to see that. And over the next couple years, I would find bottles hidden around. I was pretty good at hiding it, and they were all empty, of course. But I haven't found any bottles in a long time. And I did have a second GI bleed a few months later, and everyone accused me of drinking. And I had to convince them I wasn't. I just recently got accused of drinking that second time. It was by my daughter. She said, "I know you were drinking that second time you went to the hospital." I was not drinking. I was not. And it's hard to convince people you're not after you have. Can you hit snooze on there, please? That's my medicine alarm. I hit snooze until I take it. I don't turn it off until I take it. Well, before I was diagnosed, I had had my first HE episode about a week before. And I didn't know I had liver disease, and I was hallucinating. I was picking fights while I was fighting. And it was a nightmare. Everybody thought I was crazy. I was seeing things and brought my family into it, like, "Don't you see this? Can't you see the neighbor's tree is walking across the yard?" No one could see it. They were scared to death, and we survived that episode somehow. I didn't know I had liver disease. I didn't know until later what HE even was. But after 6 months, after that, I was referred to Piedmont Hospital. And I had to do 6 months of sobriety, 6 months of counseling. I did that. I was done drinking, but I did it. I did everything I had to do. And then y'all have some slides up here? Yeah, that's pre-transplant. That's like a few months before transplant. My kids took me to Chattanooga, and it was a nightmare. All I wanted to do was sleep. I couldn't do the things they were doing out touristing. I stayed in my hotel and slept, except for that moment. That was terrible. I was freezing cold and slept. All I wanted to do was sleep. I had an inverted sleep pattern, which nearly drove me crazy. For several years there, I slept all day long and stayed up all night. I waited on the transplant list for 3.5 years. I was hospitalized several times. I had a case of spontaneous bacterial peritonitis. One time I stopped taking my meds. I was tired of being sick. I was breaking up with liver disease and everything, and I wound up in the hospital because I stopped taking everything all of a sudden. I went to Florida and left all my medicine at home on purpose. And I had ascites. I was getting drained all the time. But I did everything I could to get on the list, and then in 2018, I started becoming short of breath. And my primary care physician said, "Tell your GI doctor next time you see her." So I did. And she said, "Tell your hepatologist next time you go." So I'm many more months out for an appointment. And then I went in, and I had been walking around for many months unable to breathe. And a nurse practitioner ordered all the right testing, and I was diagnosed with hepatopulmonary syndrome. I had to have a diagnosis for insurance to pay for oxygen for me. So before that, I had just been walking around smothering. And they still would not pay for portable oxygen. I was attached to a machine at home. When I did leave, I was able to get a handicap thing. I'd park really close, and I'd have to take breaks going everywhere and sit down. And I needed one of those chairs, like a backpack, so you could carry it around and take breaks. And I would go to shopping at Target on purpose because I could get my granddaughter to go get me a cooler that had wheels on it, and I would drag it around and sit on it. And she would do the shopping, and I would sit and rest. And I finally, after 3.5 years of waiting, my MELD score had hovered between 16 and 19 for a long time, but I got exception points for the hepatopulmonary syndrome. And I finally got the call. My MELD was 28, and I missed the call. My granddaughter had been playing on my phone, and I was in bed during the day, asleep as usual on a rainy day, and the police came to my house. And I thought, good Lord, what have my kids done now? And I went to the door, and he said that, I was listed at Piedmont. I had to switch hospitals to Emory because of insurance. So he said it was Emory calling me, and they're looking for me, and I knew what it was. I called them from his phone, and they wanted me there. They gave me 5 hours. I didn't have a bag packed because I'd been waiting so long, and I had plenty of time to shower and stuff, and then I couldn't reach my husband to get me to the hospital. And I found, like, the last minute, my son was going to take me. So we made it there in plenty of time to take a shower, pack a bag. It was June. I was freezing all the time. I packed a bag full of winter clothes. As soon as I had gotten transplanted, I was not cold anymore and had to go to Walmart and buy summer clothes. I had a bag full of these winter clothes. But I accepted a high-risk liver. They asked would I be willing to accept one, and I would have accepted any liver. And as it turned out, the liver I received was from a young man who was incarcerated at the time of death. And they just assumed that because he was incarcerated that he probably participated in risky behavior, which made it a high-risk liver. It's a public health thing. They have initials to call it. I don't know what they are, PH something. But I did accept his liver, and he took his own life. He was found unresponsive in his jail cell, and the surgeon did the recovery, told me that he went to a jail facility to do the recovery and that he had died tragically. And that was kind of unnerving. I don't care what he went to jail for. He saved my life. This guy is my hero. While I was still in the hospital after transplant, my bilirubin never went down to normal. I had a transjugular biopsy. They determined that I have Joubert syndrome, and my bilirubin's not been normal since transplant, never is. Every time someone else does labs, I have to explain it to them. They call me and say, your bilirubin's high. It stays below 4, but trending since transplant on the graph, it's always above normal. And they just say, if you turn yellow, come in, and but they're doing labs regular, every 3 months. And I was diagnosed 18 months post-transplant with diabetes from Tacro. And I was sent to an endocrinologist, used insulin for a while and kept upping my dose. It wasn't helping, so my primary care put me on Ozempic 4 years ago. I had gained weight after transplant, so I lost the 40 pounds I gained. I don't want to lose any more. Sometimes I still gain a little. I don't know how long I can be on it. I don't want to go back to insulin, but I might have to eventually. And then I found out 2 years post that I had, or no. Oh, that was something else, never mind. Anyway, I found out last year in 2024 that I had coronary artery disease. I was having TIAs, and I went to the hospital, and they sent me home and said, we found an artery with a 60% blockage, and follow up with your primary care doctor. And I did. And she sent me to a cardiologist and a neurologist. I have a pinched nerve in my neck, more than likely from the surgery. I have bone spurs and all kinds of other stuff going on in my back. And a cardiologist found a 90% blockage and 2 80% blockages. I have 3 stents now, and another one that he's watching. That was a big surprise. And I have arthritis and all kinds of old people stuff going on. And a lot of my health issues, I'm pretty sure from the alcohol. I drank for a long time, poison in my body, and I'm trying to make up for it. Can you go to another slide here? Okay, this is me. This is liver disease, low platelets, and a dental procedure. I did not know to check my platelets. My dentist did not know to check my platelets. And I had a tooth pulled, and that's what happened. It looks like I really got beat up. So now every time I go to the dentist, sometimes we always talk about what I went through, and I tell them with your patients, if liver disease, they say sometimes I have people come through, check their platelets, or you're going to wind up looking like this. It was not a fun experience. Can we go to the next one? This was post-transplant on oxygen. That was the only walk I could take because my hepatic pulmonary syndrome got worse after transplant. I took a walk the day after surgery, and after that I couldn't walk anymore. I couldn't walk anymore for another 2 weeks. I couldn't get out of bed. I couldn't roll over. I had to have help doing everything. I was desat and I was fainting. And then they overdosed me on insulin, which made that worse one day. I was in the hospital for 16 days. And then I had to stay another 4 weeks near the hospital, and I was scared to death to go home with all these tanks of oxygen. I was afraid they were going to explode in my car on the way home in the heat. But can we go to another one? There we go. That's me and my great-grandbaby. 2 months ago, she was born. Her name is Ivy. Since I've had my transplant and I have gotten sober and quit drinking, right after my transplant, my husband took me to the mountains. I love going to the woods, the mountains. I love camping. I love sleeping outside, all that stuff. And it was like just being alive all over again. I felt so alive out there. I got out of the truck and walked down the dirt road, and I'm not riding here. I'm outside. This is just like the most exciting thing. I put my feet in the creek. Then, like a few months later, I cooked Thanksgiving dinner. That was the best time ever. I had never liked cooking Thanksgiving dinner. Everything is just so new and special, and you see it so differently. And I've been able to go hiking and whitewater rafting. I saw my youngest son graduate. I have another great-grandson that I was able to see born. I do a lot of volunteering, and I participate in Liver Life Walks. I've done 4 of them. I was a champion at one of them, and I volunteer for our organ procurement organization. I've been doing that for 4 years. I love it. I have been in our organ recovery center. Our OPO leases a space in Piedmont Hospital, and they have an organ recovery center in there. I've been in there with potential donors that are waiting for matches and seen the little Uno's phone on the wall and visited with nurses and things in there a few times. It's a very respectful place, and you see the people sitting at the computers looking for matches. It's like magic is happening in there. And you see this person there. They're like on mechanical support, they're not moving. They don't wear any clothes. They cover them with paper. They have to roll them frequently so they don't catch pneumonia. They treat them with antibiotics. They come down with pneumonia. And they treat them with 3 different antibiotics in there. And then they have to keep rolling them so pneumonia doesn't set in again until they find matches. And it's sad. But some people are fixing to get life. People are getting their life back. They're going to be with their families again. They're going to get to go outside again. They're going to get to do the things they never thought they'd do again. And when I was on oxygen, I could not walk across the parking lot. And I can run around this building now. And even though I do live a life of gratitude. I'm grateful to wake up every day. I say thank you, God, for another day. And I do live with depression. I have old people ailments. I have, all the stuff I've got going on. I have a lot going on at home that is very stressful, but I'm still grateful to wake up every day. That's me volunteering there. Donate Life Month is very exciting for me. I do all the things that I can do, and I do hospital outreach with our local hospital system and go to all the hospitals. And I've worked with donor families and go to the reception that our OPO holds for the donor families each year and met lots of them and hear all their stories. I love hearing their stories. And I meet so many people out volunteering that have their own stories of donation and transplantation. And some of them are sad because a lot of people have people that didn't make it. And I'm one of the lucky ones. And I cannot think of a better way, like anything that can make you appreciate life more than facing death and being so close to it. And I don't advise that for anyone to have to go through, but just pretend that, well, we're all dying. We are all dying, and life is short. Jen knows what I'm talking about. It's from a podcast. We are all actively dying. When you are eating a sandwich, enjoy that sandwich because death is on the other side of it. It might not be tomorrow, but it is coming eventually. And I try to enjoy those sandwiches. And most of us count down the days that we're here on this earth. and I have had 6 years and a couple months and 17 days extra bonus days counting up. And I'm going to keep on counting up. And I'm done. Thanks, y'all.
Look at Nana there. That's great.
That's my before and after. That's my true before, not the one in the hospital where I'm laying in the bed hooked up to everything. That's what most people show is their before. That's mine with a drink in my hand, 50 pounds overweight. And this is Mount Yona in Georgia on the top, one of the hardest hikes we have in Georgia, and I did that last summer, and climbing to the top of the mountain is a pretty big feat for me after not being able to breathe for so long.
Right.
And I'm going to find more.
You are an inspiration. Thank you. Thank you. Well, now we move on to just an opportunity for question and answer for the panel. You had all the way from research to what I think is the real focus of everything, of just transformation of someone's life. So we'll have microphones coming around. So. And maybe just to introduce yourself and a little snippet, maybe even about yourself.
Hi, I'm Allie. So I'm currently going to school to be a surgical assistant. So I was just, sitting here looking at the presentations, thinking about like my anatomy classes. We're currently diving really deep into the endocrine system. And I was just wondering if you'd be able to tell me a little bit about, you were talking about like cancer and the liver and the pancreas and all that good stuff, which is obviously part of the endocrine system. I was wondering if that cancer will affect any other of the glands, like the thymus on the heart or the pineal gland, or like any of those other ones.
So directed at Dr. Hughes, I guess.
You want to take?
No, go ahead.
Cancers of those areas usually don't affect the other endocrine organs, like cancer of the pancreas usually is of the pancreas and doesn't affect some of the other, endocrine things we consider endocrine, like thyroid or whatever.
Thanks.
And the pancreas is really aggressive. Thyroid cancer can be aggressive and can spread as well, but they usually don't affect each other. It's originates in one, and we treat it as separate types of cancers. And they have different treatments as well. Yeah, I think when you get cancers, though, I think a lot of that breaks down. I think the cancers really, like a liver cancer, for instance, it doesn't really function like a liver anymore. Its purpose is just to grow. And so it stops really sort of doing its normal functions. Everything is directed toward growth. And so I don't consider once somebody gets a cancer in an organ or like in an endocrine organ that's really a functional type. You can form like nodules, like benign nodules, which can function and can hyperfunction. But usually when it comes to cancers per se, they sort of lose their function and direct everything toward their growth and their sustaining of their blood supply and oxygen supply so that they can grow. Yeah.
Bruce Dimmig, MASH patient for HCC. For HCC monitoring. How predictive and how accurate is AFP in doing that?
Yeah. Well, I can, I'll say Dr. Manga does a lot of biomarkers in his lab. So I'll just say that on the clinical side, and then maybe Dr. Manga can talk a little bit about biomarkers, but alpha fetoprotein is one of many biomarkers we use to look for hepatocellular carcinoma. There are many others, and there are different types of alpha-fetoprotein. Some subtypes are a little bit more accurate. So in the clinic, when we're screening for liver cancer, we use the alpha-fetoprotein usually about every 6 months, but in conjunction with pictures. So typically either an ultrasound or a CAT scan or an MRI. So it's part of a whole screening regimen, not an individual piece. Not all cancers, liver cancers or even hepatocellular carcinomas, will make that alpha-fetoprotein. So sometimes you'll have a cancer, but the alpha-fetoprotein won't be elevated, and sometimes it will be elevated, and it could be just from inflammatory processes of the liver, like a viral hepatitis. We see it elevated in hepatitis B or hepatitis C. So it does take some interpretation there. Paul, can you talk about any special biomarkers that you're doing in your lab?
Yes, there are several that are being looked at, specifically when it comes to metabolic dysfunction-associated liver disease or MASH. But they're not ready for prime time at this point. But I would say, as Dr. Biggins mentioned, the best combination right now that is clinically accepted is alpha-fetoprotein and ultrasound combination. So if you're getting that, I think that's as good as it gets for now, until some of these other, because we don't really know what is causing cancer in fatty liver disease patients. So once we are able to identify, then we'll be able to identify something that is released by those cancer cells that can be detected in the blood.
Yeah, currently under the SRI protocol, so.
Perfect.
Great.
Well, you know what I'm trying to say.
Yeah, yeah. Great question, though.
Yeah.
Any other questions? We have the microphone coming around and a few hands up. One in the back and then a couple up front.
Good morning, everyone. My name is Rhonda Cowan. I'm from Louisville, Kentucky. I have a question in regards to being a donor. I am a long-term survivor of HIV. I was diagnosed in the early 90s when I was in my 30s. I'm still standing. I just had my 66th birthday last Saturday. I also have worked in HIV, hepatitis C, outreach testing, prevention, and linkage to care. I currently work in harm reduction now. My question is, if you wanted to be a donor and you're HIV positive and your U equals U, and my understanding is that if anyone's exposed to any of your bodily fluids, that they won't be affected by HIV. So would that make it possible for you to be able to be a liver donor or any type of organ donor?
Yeah, it's a very good question. There have been some evolution in accepting donor organs from people living with HIV who have now died. And that's been put forward by what's called the HOPE Act. It's different than the HOPE that was here on the perfusion devices, but individuals who have HIV and need an organ transplant can accept organs from individuals who were living with HIV. So it is still possible, and it'd be maybe something that we can connect you with our OPO folks. Laura, do you have any comments on that?
Yes, on the donation side, HIV does not exclude you from being a donor. And actually, we do have occasionally a few donors every year that have HIV positive. What we do on the donor side, we do send off additional blood work when we do the initial workup after authorization to test the viral load. So that way we can share it with the transplant surgeons as we're making offers. And the recipients are made aware, because when we run the list, there's certain recipients that are willing to accept an HIV organ. So we work off of those lists for allocating. And honestly, there's always a need. There's always a need that we can have, donor heroes and make that gift happen. So yes.
And thank you for signing up to be a donor and that willingness. You can see the benefit that can happen from this. So wonderful. Thank you.
Can I add to that?
Yeah.
When I received my high-risk liver, I was willing to take that risk. I was tested every 3 months for the first year for all the hepatitis and HIV. And that was a possibility just because my donor had been incarcerated. You know, that makes you a bad guy,
Great.
apparently, some people.
Thank you. Over here.
Hi, I'm Jen Jones, and I was a founder of Sober Livers. We're a fatty liver foundation program. First, Nancy is just a blessing to us as well. She is an advisor with us and our Facebook administrator, so we are so thankful to have her part of our team. And thank you for being raw, authentic, and inspiring. And then I had a question for Dr. Hughes, two actually, so I apologize. The first one was the histotripsy. You said a resurgence, because I had read, I guess it's going on 2 years now, when Michigan Medicine had Edison that came into play. Was this something that was in the past before?
Well, histotripsy, like lithotripsy, it's just been a procedure that's been available to treat different things. So not necessarily for treatment of liver tumors, but treatment of certain types of diseases. It's all based upon the same premise as far as the science behind it, with the use of sound waves to try to break up whatever it is, whether it's break up tumor cells or break up a kidney stone. Essentially, the technology is sort of the same. So it's being sort of evolved, I guess might be a better word than resurgent, sort of evolved into treating liver tumors.
Okay, great.
Can I add to that, please?
Yeah.
I just wanted to add that the hospital in my little town of Gainesville, Georgia, was the first hospital in the world last year to do clinical trials for liver cancer histotripsy.
Woohoo! And then my second question involves iron and iron in the liver. Fortunately, I was put on iron when I had very low iron when I had decompensated cirrhosis back in 2018. My PA prescribed, hepatic PA prescribed taking 2 iron pills a day, which I did religiously and continued to do religiously. And unfortunately, she stopped checking my iron once my iron got normal. And 2 years later, I started having major stomach issues. And my ferritin was upwards of over 850, which is very high for anybody that doesn't know. I think it's like 503 or something for women that you should be at. And it took a very long time for that iron to come out of my liver. And we monitored it on MRIs and specialized MRIs. But from things that I've read, I used to be a health researcher as well, that iron in the liver is kind of like a breeding ground for cancer. Is that a true statement, or can you explain how iron works in the liver?
I can take the first part of that question, and then I think we'll go into tumor genesis, maybe from the lab. But when the body is just really set up to store iron. We need iron to build blood cells, and there aren't many ways to get rid of iron other than bleeding. And so there's a difference between men and women because of menstruation cycles, it will bleed, but it's really hard to get rid of iron. Sometimes there are some liver conditions where you absorb iron in an abnormal fashion, and excess iron can do that. That's called hemochromatosis. Some people will have one of those genes. Some people will have 2 of those abnormal genes and can lead to excess iron storage. But a lot of times when people have inflammatory processes, those markers are high. The ferritin levels can be high. A lot of times when people have advanced liver disease, they can have bleeding, like we heard today. You can also just have loss of the ability to absorb iron because you have swelling of the intestines and things. So many times when you have cirrhosis, it is good to get iron supplementation. It sounds like you had a little bit of that iron, when it comes in a pill form, can upset the stomach quite a bit, and actually make your poop look green, sometimes black, which can be alarming that it might be blood, but it's not. But once you do get on that iron, it is important to figure out, are you now replete because your liver is doing better, your body might be doing better, and figure out not just go on one pathway and stay on it, but have some regular assessments. In terms of the predisposition to get cancer when you have iron in the liver, the hemochromatosis, those excess iron, circumstances where the liver has a lot of iron do put you at higher risk for cancer, but that's because of the underlying disease, maybe not all because of the iron itself. Now, at the cellular level, all that signaling that's happening and the connection to different liver tumors, I'll pass on to the basic scientists. So, Paul, can you give a sophisticated
You have
answer
something
there?
to no, okay. Well, I think the easiest way to say is that yes, excess iron deposition in a liver cell, in a hepatocyte, can eventually cause stress to that hepatocyte. Once a hepatocyte is stressed for a very long time, it can start releasing things that brings inflammatory cells around it. And if you get those excess inflammatory cells, they are going to release some things that are going to then cause free radical injury to the cells. So excess of everything is bad. Just, so excess of iron can also be bad. So I think as Dr. Biggins mentioned, I think the best way to think is once you're repleted, after that you got to be monitored, because if you feed excess iron diet to mice, to people, they're eventually going to start to cause hepatocyte damage, which can cause inflammation, fibrosis, and anytime that happens, you're at a high risk to develop cancer.
Great question, inspiring lots of our experts here to that. Chris, did you have extra to add to that? No,
that was a
Oh,
good
okay,
answer.
all right. So we have a question here.
Yeah, good morning, everybody. My name is Brian Evans. I'm with AstraZeneca. I just have a question to the panel. When we're talking about bridging strategies, what are your thoughts or experience on the inclusion of immunotherapy agents as part of a bridging strategy, especially to address some of the micrometastasis that you mentioned before that maybe don't show up on scans but can cause trouble down the road for patients?
Chris, do you want to take that?
Well, I think, we'll do, number one, next generation sequencing to look at if there's any targetable therapies for tumors. In general, I think immunotherapies, unless there's a direct focus, something for us to target, we don't just sort of randomly put people on an immunotherapy. And if we did, it would be sort of well, we've tried everything else, let's do this. I don't know if, Paul, you think that's...
No, I think in a transplant setting, you have to be extremely careful, right? Because it's complete opposite of what you're expecting post-transplant. So if you want to stimulate your immune system to kill cancer, that's what immune checkpoint inhibitors are going to do. Then once the tumor dies, the effect can still linger on. And once a new liver is put in, you can imagine that immune cell can turn on. So in that setting, I think in resections, yes. It's new in both neoadjuvant and in adjuvant settings. Immune checkpoint inhibitors are very, very commonly given. But if it's a transplant candidate, at least so far, it's not indicated.
So I'll add to that, and then there's often a washout period for the checkpoint inhibitors when we go into a liver transplant, and this is where when Dr. Hughes was talking about the live donor transplant, it's very helpful to be able to know when that is, so ahead of that you could stop the immune checkpoint inhibitors going into the transplant so you don't induce rejection on the other side. At UPMC, we have a very novel clinic, which we opened up probably about 4 months ago, and it's still getting up and launching. We call it the Beacon Clinic, and this is a a clinic where we have a transplant physician, so a transplant hepatologist in the Hillman Cancer Center. We have a GI oncologist that's in there, in that center, and we have a multidisciplinary approach with the idea that we should be able to use the whole quiver of cancer treating agents, including immunotherapies, after a liver transplant or after a solid organ transplant, understanding you're threading the needle between seeking a cure or a treatment of that cancer that could be a melanoma that came back after an organ transplant that responds very well to immunotherapy, and trying to avoid the rejection of that liver there. And so this is one of 2 clinics like this in the whole United States where we're having a multidisciplinary focus on how we use immunotherapy in the setting of treating cancer for solid organ transplant recipients. So that's very unique right here in Pittsburgh. Any other questions? One back over here.
So Emily Ventura, I am from the PFIC Network Patient Advocacy Group. I also have a daughter with PFIC. She had a transplant when she was 5, not from hepatocellular carcinoma, but I know many patients in our rare disease population that, are impacted by that. But my question is pretty general, and to anyone on the panel, but drawing back, Dr. Hughes, to your slide about the patient at the center, and then all of the different spokes. And your piece is just, you replace the liver. I loved that.
Orangutan, I think you said.
So, the theme is patient empowerment, and I liked what you referenced. Patient empowerment stems from options. But if you think about that patient in the center, it's one thing for them to know their options. It's the other for them to truly understand those options. And you have all of these different spokes involved in that. So in PFIC, my daughter's treated in the pediatric system, which is different than the adult system. So I think it's more in your opinion or in your experience, what do you think the best, or what have you seen as the best approach to helping the patient navigate that choice so that they really are a part of that choice? They're patient-centric and empowered to be a part of that conversation to make the best decision for them as a patient.
That's a great question. I think it's our responsibility. And the reason there's so many people involved in making decisions like this is it's so much information. I mean, there's no way that I can keep up with all the advances that I need to and all the new drugs coming out for chemotherapy and immunotherapy and understand the basic science behind it. That's why it takes so many people to kind of, here's my expertise I'm putting in. But I think it's upon us, and we make a lot of decisions this way, whether a person is a transplant candidate, are you going to get a transplant, or do we think you're not a candidate? I think it's up to the physicians to work together to give the best option to the patient and then educate them as to why that's the best option. Because patients are going to come to you and they're going to have read about, maybe they've read about all these different things and they like this certain one. They like radio frequency ablation, and that's what they think they want to have. Well, that may not be the thing. Your tumor's too big for that. Your tumor's close to a vein. We can't use that. Because the heat will be suctioned away by the vein flow, the blood flow in the vein. There's so many nuances in it. I think it's, and you have to put it in terms that the patient understands. And so if you do that, most patients are like, wow, that's the first time that anybody has explained this to me this way. And that's why when a person comes in for a transplant evaluation to us, and they've been referred to us to see if they're a candidate for a transplant, it's a 3-day evaluation. They get a lot of tests done, they meet different people from our team, but half the time is people sitting in the room with them and educating them about, here's why you need to understand your nutritional status. Here's why physical therapy is important. Here's why we're going to do such and such in the operating room. Here's why you have these certain risks in the operating room. That's my part. But you have all these people who weigh in on it. I think if people get all giving their expertise, if they're able to explain it, I think that's the best patient care.
I'll second that as the hepatologist who often is funneling all those different specialties into this. You know, it'd be very hard and frankly, I think overwhelming for some people to try and assimilate that. It's actually hard for us as the clinicians to assimilate that. Oftentimes, there's a clear winner in terms of a suggested pathway forward. Sometimes there isn't, and there might be a bit more of a menu of 1 or 2 or 3, and that is where you do sit down and say, okay, well, what do you want best out of your life? What are your values? What do you really seek? And I can think of a clinical situation, for example, something called a TIPS that many of you may have heard of, to put a shunt in the liver to decompress that high pressure. Now, that doesn't cure the liver disease, but it can change one problem for another problem. So you can have ascites in the belly. We have this big belly full of fluid, and that tip shunt can make that go away. But on the other hand, you can develop more difficult to control confusion or encephalopathy. And so this is an example of where I will sit down with a patient and say, what do you value most in life? Do you value not having to go into the doctor and get your paracentesis or the fluid drawn off of your belly every week? Or are you a truck driver who, if you were confused with your encephalopathy, you might be able to have your livelihood and to figure out what the values are. But sometimes it is so clear this is the right thing, and you have to sit and listen to the values and bring that multidisciplinary expertise right to the patient and say, there is a big menu, but this is what we really think, to be able to not overwhelm with what is a challenging circumstance. Well, we are right at our time at 11. These have been great questions, a wonderful panel. Thank you to all of you, especially Nana, for sharing your journey. And after this, I believe we have some breakout sessions, so I'll hand this over to Susanna and the CLA folks. Thank you for all your attention.
I do have to add something. I was requested to add.
Yep. One more addition closing.
Okay, just one thing
Yeah.
I was requested to add to say that when someone is transplanted and they go home, they want to already know they don't have a gallbladder. That is a very popular question.
Yeah.
So let them know.
Yep.
Put it
Good.
on the discharge paper.
All right, it's
Hey,
there.
gallbladder.
Thank you. All right.
Oh, thank you. Yeah.
Let us thank all of our speakers once again. Are they amazing? This day 3 is just equally as amazing as the first 2 days. I have an announcement. Somebody left their sunglasses on the boat last night. Do these look familiar to anybody? If they do, I will have them for you. We now have a break for 15 minutes, but I do want to let you know where you're going. I'm going to tell you where to go next. So at 11:15, our second set of breakouts start. So the Evolving Precision Medicine in HCC from bench to bedside with Dr. Monga will be in Brighton's 3 and 4, which is upstairs. So you'll go to floor 2, and it is right above where the hotel registration is. So just take the elevators or the stairs up to 2. The AdCom 101 will be in Grand Station 3, which is next door. Liver cancer will be in Grand Station 4 and 5, which is behind us. And core transplantation will be here in this room. So, and you can find all of this information on the app as well.